Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
According to the Centers for Disease Control and Prevention, 30 million people, which means 15% of the adults in the United States, have chronic or long-standing kidney disease. Chronic kidney disease, it's also known as CKD, usually results in the gradual loss of kidney function. And in case you didn't know, your kidneys filter waste and excess fluids from your blood, and then that stuff is excreted in your urine.
Stuff? Is that
stuff,
a medical
the bad
term?
stuff.
All right. When chronic kidney disease reaches an advanced stage, dangerous levels of fluid, electrolytes, which are salt and minerals, and wastes can build up in your body. Treatment for chronic kidney disease focuses on slowing the progression of the kidney damage, usually by controlling the underlying cause. Here to discuss CKD is Mayo Clinic nephrologist Dr. Latonya Hickson. Welcome to the program, Dr. Hickson. It's great to meet you.
It's great to meet you as well. Thank you for having me.
Good to have you on the program, Dr. Hickson. 30 million people in this country have bad or poorly functioning kidneys?
I know, it's a scary thought, honestly. But that's the statistic. And unfortunately, in 2015, over 700,000 individuals had such bad kidney failure that they were classified as end-stage kidney failure and either required a kidney transplant or renal replacement therapy in the form of dialysis.
What causes kidney disease?
Yeah, and why is this so prevalent?
Yes, well, one, we're all getting older, sadly.
Not me.
And, well, some of us are getting older.
Okay,
How about
all right,
that?
good.
And when we think about it, once we hit around the age of 40, we all lose about 1% of kidney function per year. So if we live to be 120, for sure, we're going to have chronic kidney disease. So some of us have chronic kidney disease just by the mere fact that we're getting a little bit older. And maybe we didn't start off with the healthiest kidneys when we were first born or in the early stages of life, or we've had different injuries as we go along. But I don't want to miss the opportunity to say the most common causes of kidney failure are diabetes and hypertension. And of those over 700,000 individuals we talked about that had end-stage kidney disease, over 75% had either diabetes or high blood pressure as the cause of their kidney failure.
Is it true that if you could control those two things, first of all, you have to know that you have either high blood pressure or diabetes. If you control your blood pressure, if you keep your blood glucose under control, you can prevent kidney failure?
Well, I wish it were that simple. Some of us, unfortunately, are genetically predisposed in a way to have kidney failure. Now, maybe we are genetically predisposed and there's only that one additional hit that if we just could have laid off of that last piece of cake, or those remaining 50 pounds that we gained over the course of life, then maybe we would not have gotten kidney failure. But unfortunately, due to diabetes, at least a third of those individuals may go on to develop kidney failure, whether they've potentially had perfect control of their diabetes or not. And that's the sad part about diabetes. Now, high blood pressure, I think that we can definitely make a case that if we knew that we had high blood pressure early on and we'd gone and sought medical care, that maybe we could have prevented some of that.
As we were getting started, I said when it reaches an advanced stage, you get dangerous levels of fluid, the electrolytes are out of whack, and the waste build up in your body. Can I feel all of those things happening? Do I just get really sick, or how do I know that I have CKD?
Yes. CKD is a very silent process in the beginning. And so as Dr. Shives pointed out, well, when we're going along and we're feeling perfect, we may not know really that we have these early stages of chronic kidney disease. Now, yes, the kidneys are such smart organs, okay? And they filter the blood and get rid of waste products and the extra fluid that's in our body that we need to get rid of. They take care of that for us without us worrying about it. When we develop more advanced stages of chronic kidney disease, we begin to notice that they're not doing their jobs. With certain kidney diseases, we may lose so much protein in our urine that when we go to the restroom, it looks like we poured beer in the toilet. The foam that builds up from all the protein that's lost. Now, in other cases,
That would be sad.
Yeah.
by the
So
way.
foamy
Yeah,
urine is something to be
that's
concerned
right.
No,
about.
I meant, beer
well,
in
lots
the
and
toilet.
yes, right. Why waste it?
So
you
sad.
know? Yes. But it's definitely one of the questions we ask in certain forms of kidney disease. And for certain, when we think about the great job that the kidneys normally do of getting rid of all the fluid in our body that we don't need, once we start to gain a lot of water weight or fluid weight and we become short of breath, those are very classic signs that things have progressed.
So is it easy to diagnose, or is it tricky?
Can be, yes. And that's the nice thing about kidney disease, which is part of the reason why I went into the field of nephrology, is there's concrete evidence that there's something wrong with your kidneys usually. And that can be easily found out by a blood test, a simple blood test, and a simple urine test can give you the information.
You do a urinalysis also, and can that help? So it's
Absolutely.
it's basically two things: urinalysis and blood test.
That's
right?
correct. Yes. In the urine, we are looking for the amount of protein that we lose. So we have protein that do these essential jobs in our body, and they normally stay in the blood. But when the kidneys are damaged, the kidney becomes a little leaky. That filtering apparatus doesn't do its job. And then we begin to lose those important proteins into the urine. And if we do that urinalysis, we can look and see how much protein's in the urine. But we can also find out other little clues that tell a nephrologist or a physician or a healthcare provider that there's something wrong.
You know, we have two kidneys, which I don't think anyone knows why we have two kidneys, but do you ever see a situation where one goes bad and the other one keeps working? Because people who have just one kidney have a normal life expectancy,
Yes,
right?
they do, particularly if they did a beautiful thing called kidney donation. But for sure, we can have one kidney that goes bad and one that is healthy. But I'll say that the times when that happens, there's usually a problem with the blood vessels that lead to the kidney and can make that one kidney have a problem. And that's generally called Rino vascular disease. Mostly we see that what's happening in one kidney ends up happening in the other kidney.
Which blood test is it that tells you whether or not the kidneys are functioning
Great
well?
question. The easiest test that I can tell you about is the serum creatinine.
Serum creatinine.
That's
Is
right.
And if you get a general physical exam, is that a test that you would normally get?
I think everybody should have it. Okay. Now, different societies have disagreed with the nephrology community, and we're kind of disappointed about that. But yes, it's very easy, and I think it's pretty darn cheap too. But it's a serum creatinine that gives you an understanding of how the kidneys are functioning. And not only that, there are beautiful equations that are available now that help calculate your age, your race, your sex or gender, and we can put all that information together and tell you what, I'll say percentage or what rate your kidneys are functioning at.
And is it a situation where if it's diagnosed early, you can save the kidney, or is damage done, damage done?
Just as in life, yes, sometimes damage is done and that's all you can do. But what if we catch it early? What if there's an underlying cause? Let's say that you have inflammation in the kidneys from a glomerulonephritis process or vasculitis, and it hadn't gotten to the damaging stage where it's irreversible. Yes, if you'd gone into the doctor for that workup and gotten that one simple test and the urine test, then we'd be more likely to treat early. Or if you have diabetes or high blood pressure, then when you go into the doctor, if we see signs that things are moving in the wrong direction, then maybe we can make recommendations, which will certainly include lifestyle changes too.
All right, so the two most common causes of chronic kidney failure in this country are diabetes, high blood pressure. To get your kidneys checked, you need a couple of tests, the urinalysis and the creatinine, blood creatinine. And I think the other important thing that I learned this segment is that if you've got foam in the bowl, after you relieve yourself, you may potentially have a problem.
That's a bad thing.
Yeah, we're talking about chronic kidney disease with Mayo Clinic nephrologist, kidney specialist, Dr. Latonya Hickson. Time for a short break. When we come back, we'll talk more about chronic kidney disease, including treatment options, prevention, and Dr. Hickson's going to tell us about her research.
You're listening to Mayo Clinic Radio on the Mayo Clinic News Network.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are back talking with kidney specialist Dr. Latonya Hickson about chronic kidney failure, chronic kidney disease. 30 million people in this country have chronic kidney disease. We've talked about the most common causes. We've talked about how you make the diagnosis. We need to talk about treatment. What do you do about it?
Well, I'm excited to talk about treatment because that's what we do every day. Now, treating chronic kidney disease is a little more complicated. We don't have a lot of things in our toolkit that we can really reverse kidney disease or the progression of it, unless it's due to some of those things we mentioned, like glomerulonephritis or vasculitis. But we can all do something in terms of...
Glomerulonephritis or vasculitis. Tell us exactly what you mean by that.
Thank you for giving me that opening. Yes. Now, those things that I mentioned are things that are basically inflammation in the kidney.
Okay.
And it could be due to an underlying systemic process like lupus, systemic lupus erythematosus. Or it could be due to vasculitis, like what we term ANCA vasculitides. And those things can also damage the kidney.
And so that's inflammation of the blood vessel itself that supplies the kidney.
Very good. Excellent. Okay. Man, I think he wants to be a nephrologist and do his other jobs too. That's right. Very good at this.
Orthopedic surgeons.
I know. They do it all.
Yeah, you got to talk very, very slowly. I'm from Iowa too.
Well, I'm from the Carolinas, so I love talking slow.
Oh, good.
And in the clinic, what we do is recommend for sure healthy lifestyle. And so when we think about that, most of us could afford to lose a few pounds. Now, you guys are perfect, but I'm with the rest of America that needs to lose a few more pounds, okay? We need to change our diets a bit and make sure we cut down some of the sodium and the other things that may exacerbate our blood pressure or make our blood pressure worse. If we smoke, sorry, but this is another reason to give up smoking. And then we need to exercise and do other things. Now, in the clinic itself, we will generally give individual patients medications that help reduce the stress on their kidneys. And then we walk them through the process of understanding the implications of kidney disease. And it's our job to be there and help them through it.
No, in the first part of our interview, you mentioned that's one of the reasons why I got into nephrology. So tell us, why did you? Why did you decide you wanted to become a nephrologist?
Well, let's see. When I was in North Carolina doing my residency training, I was trying to figure out, did I want to be an orthopedic surgeon? No, that was not going to work out for me, okay?
Yeah, look
Just
what
too
happened.
short and not strong enough, But I was in my internal medicine residency, and I looked around and I thought, how can I make a difference? What disease process can I treat every day and I know that it's really there? And that's definitely the place for chronic kidney disease. As an African-American individual, I also saw right there in North Carolina that there were disparate rates of individuals affected by kidney failure. And I wanted to make sure that I helped contribute to the community and contribute to medicine alike, which is what got me here at Mayo Clinic. I wanted to go to one of the best institutions to train to become a kidney specialist.
And you can also do a fair bit of research here at Mayo Clinic. So tell us about what are you researching?
Well, I'm really excited to talk about research in chronic kidney disease. And I am a part of an amazing group right here at Mayo Clinic that is investigating the regenerative aspects of kidney treatment. Ooh. And our group primarily assesses mesenchymal stem or mesenchymal stromal cells. And our goal is...
So these are cells inside the kidney?
Well, good point. Okay, so I should clarify. Now, these cells are adult stem cells. So we all have them. And what we do is we take these cells from our abdominal fat. So I'm very happy to give you a little bit of fat tissue right underneath the skin around my belly button. And amazingly, we take these cells and we harvest them. And these cells we can inject back into the body for them to do good. And they basically tell the kidney or other organs systems that are impaired that they need to wake up and get back to work and help heal that organ system. Now, Mayo Clinic has a good number of trials. I believe there are over 12 clinical trials ongoing right now that from our regenerative medicine fields that are trying to do their best to repair organs that obviously can't do it on their own. And our goal is to do that in the next few years and take a look at how we can repair the diabetic kidney in terms of delaying the rate of progression of kidney failure.
And your research is going to show that in the next few years?
Well, we're going to begin our trials. Gosh, I wish research were that quick to turn around.
Okay.
But no, our goal is to begin the clinical trials in the next few years.
Gotcha. Fantastic. And I hope we get there sooner rather than later. But we're not there yet. So I want you to talk to us about dialysis. So someone has end-stage kidney failure. Their kidneys have essentially completely quit working. A lot of these patients are diabetes. Some of them are diabetic. Some of them have high blood pressure. Tell us what their options are. Obviously, kidney transplant, one is an option, but there's a waiting list, and not everybody's a candidate. So what do you do if your kidneys? There are a lot of people alive who have kidneys that are non-functioning.
Yes,
how do you keep them alive?
And in 2015, over 400,000 individuals were utilizing renal replacement therapy, and that would be dialysis therapy, okay? Now, over 700,000 individuals had end-stage renal disease, as you pointed out. So what are the options for those people that are on dialysis? Some really amazing people that I've met over the years. The options consist of two things. One, the dialysis treatments can be done using the blood as the source, or using the peritoneal cavity or the peritoneal lining as
abdomen.
the filtering apparatus. So that is a blood dialysis known as hemodialysis, or peritoneal dialysis, which is that abdomen that you spoke of. And then we talk about where the dialysis is being performed. Are we doing the dialysis at home? And so those are home renal replacement therapies. Are we doing it in the facility or a center? So that's in-center dialysis. And so there are around 3 options that we generally talk about. The home hemodialysis, so that's home dialysis where we use blood and we hook the individual up to the machine with some needles, generally in the arm, or a catheter. Then there's home dialysis, which could be peritoneal dialysis. And this dialysis is kind of cool. You have a catheter that's placed in the abdomen, and there's fluid that bathes the insides of the abdomen, gets rid of the waste product, and then it basically can be flushed down the sink. And this whole treatment can be done while you sleep. I like that option too. And then, of course, there's in-center dialysis, which we can offer for everyone, whether they have the ability to do the dialysis treatments at home or they need more care. And there are wonderful people that staff those clinics that have a lot of fun with the patients there. And in-center dialysis is generally done 3 to 4 times a week over a 3 to 4 hour interval. But we're getting kind of fancy. We're doing peritoneal dialysis in center as well. And so there are more options around the country.
Well, thank goodness there are those options, because there are a lot of people who need them. How many people did you say every year get dialysis?
Well, every year, it varies, but say in 2015, around 120 to 140,000 individuals were newly diagnosed with end-stage renal disease. And they joined a whole pool of over 700,000 people that had end-stage renal disease or end-stage kidney failure.
We hope you speed up your research.
I'm hoping so too. Thank you so much for the well wishes.
Yeah. Nephrologist, kidney specialist, Dr. Latonya Hickson, thanks so much for being with us.
Thank you all.